Inquisition and physical examination flow. Prepare and check the amount of instruments. A stethoscope, a mercury sphygmomanometer, a glass thermometer, tongue blades, a percussion hammer, an electric torch, a ruler, a marker pen, articles for hand washing, etc. Self-introduce. Give a brief self-introduction and communicate with patient shortly. Meanwhile, introduce the purpose of body examination briefly so that the patient can cooperate in return. Body examination. Stand at the right side of the patient. Keep the patient in supine position. General inspection. Wash hands in front of the patient. Talk with the patient and observe the general condition, including the development, state of nutrition, facial features, expression, voice, tongue, posture, and consciousness. Measure the body temperature at the left axillary fossa for 10 minutes. Make the mercury column at 35 centigrade Celsius, and then put the thermometer in the left axillary fossa. After finishing the head examination and before the check of neck, take out thermometer and record it. Palpate radial artery and count the pulse for 30 seconds and multiply by 2. Let the patient relax hands onto the abdomen. The doctor uses examining fingers, the index, the middle, and the ring fingers together to palpate the radial artery for 30 seconds and compares the pulse of bilateral radial artery at the same time. Stares at thorax to record the respiratory frequency for no less than 30 seconds. Measure the blood pressure of the right upper limb twice. Pay attention. First, the patient should not have had alcohol, tobacco, caffeine, or performed vigorous exercise within 30 minutes of the exam. The examination room should be quiet and the patient comfortable. Position the patient's arm such that the antecubital fold is level with the heart and the arm is slightly flexed at the elbow. Empty the cuff to make sure mercury column is at 0 point. Center the bladder of the cuff over the brachial artery, approximately 2 to 3 centimeters above the antecubital fold. Wrap the air sleeve around the upper limb adequately. It would be better if it is allowed to put one finger in the air sleeve. Second, place the stethoscope over the bronchial artery, turn off the valve, inflate the cuff until the sound of bronchial artery disappears, and then inflate the cuff to 30 millimeters of mercury more. Release the pressure slowly, no greater than 5 millimeters of mercury per second. Notice the position of mercury column. When you hear the first pulsation, the scale indicates the systolic pressure. Continue to lower the pressure until the sounds muffle and disappears. The scale indicates diastolic pressure. Attention, both of them are even numbers. Third, measure again. Make sure the cuff is empty and the mercury column is at 0 point. The accurate blood pressure is the mean number of two blood pressures. Head. The skull. Inspect the size, shape, abnormal movement, color, and distribution of hair, the type and the characteristic of alopecia. Part the hair to look for the scalp, curve, and then palpate the skull to identify any areas of tenderness or deformity. Eyes. Everse the upper and the lower eyelids and observation of abnormality of eyelids. Let the patient look upwards and downwards to observe the scleral. Put an object, cotton bud or finger, before the patient at a distance of 30 to 40 centimeters. Tell the patient to keep head still and move the elbow as the object does. Generally follow the order of left, left upper, left lower, right, right upper, and right lower. Direct light reflex. Irradiate one pupil of the patient directly. Observe the change of pupil size. Indirect light reflex. One eye is irradiated and the other pupil constricts. The pupil enlarges after moving the light. When examining, the doctor should block light by one hand to avoid the light irradiating the examined eye to cause direct light reflex. Convergency reflex. The doctor shifts his index finger from 1 meter away to the eyeball 5 to 10 centimeters gradually, and tells the patient to notice the finger. At the same time, observes the movements of the eyeballs. Ear. Inspect the auricles and posterior areas of 2 ears, and palpate the bilateral external ears and mastoid. Examine the elevation of 2 ears. Twist the fingers or by watch. Nose. Inspect the visible nasal structures and note any swelling, redness, drainage, or deformity. The methods to examine nasal sinuses are listed as follows. Maxillary sinus. Press upwards under both maxilla with the thumbs. Frontal sinus. Press upwards under both eyeballs with your thumbs. Ethmoid sinus. Press backwards at the point between the root of nose and angulus oculi medialis with the thumbs. Oral cavity. Inspect the lips and then ask patient to open his mouth. Using a wooden tongue blade and good light source, inspect the inside of the patient's mouth, including the teeth, gums, tongue, buccal folds, and under the tongue. Inspect posterior oropharynx by depressing the tongue. Note any tonsillar enlargement, redness, or discharge. Neck. Inspect neck for asymmetry, skin, and carotid artery pulsation, then check the activity of cervical vertebrae. The lymph nodes of head and neck. The methods of the palpation of the lymph nodes. Sliding palpation with the index, middle, and ring fingers together, and palpate the local skin by finger bulbs. Mutual vertical directions or rotational slide is necessary in sliding palpation. When examining the lymph nodes of head and neck, ask the patient to lower his head slightly and to bend their neck toward the side you are examining to relax the muscles. The doctor's fingers contact the examined part tightly, sliding palpate from superficial to deep. The general order is preauricular, postauricular, occipital, submandibular, submental, anterior cervical, posterior cervical, and supraclavicular lymph nodes. Take out thermometer and recordate. Anterior and lateral chest. Inspection. Lung and chest. Expose the chest adequately. Observe the contour, symmetry, wings of chest wall, skin, intercostal space, respiratory movements, diaphragmatic respiration in male, thoracic respiration in female, and observe the symmetry, surface, skin of breast and navel. Heart. Eyes are at same level with the patient's chest so as to observe the apical impulse, pericardium eminence, and abnormal pulse. The size should be tangential with apical area. Palpation. Axillary lymph nodes. Take the patient's left arm with your left hand and support it at the elbow. Ask the patient to let you take the weight of their arm and with your right hand palpate the patient's left axilla. Begin by palpating deeply towards the apex of the axilla with the pads of your 3 middle fingers in a circular motion, and then examine each in turn for apex, central, anterior, posterior, and the lateral group. Note any abnormalities of the lymph nodes. Then repeat at the right axilla. Lung and the chest. Press the chest wall and sternum slightly, from upper to lower, compare the bilateral sides. Identify any areas of tenderness or deformity. Place the ulnar side or palm of hands at the anterior inferior lateral parts of chest wall. Ask the patient to breathe deeply. Palpate whether there is the sensation of friction, just as scrub of leather. Place hands at the anterior lateral parts of the inferior chest, with thumbs pointing to xiphoid process along the costal margin, and tips are at the symmetrical position of anterior midline. Meanwhile, the palms and stretched fingers are at the anterior lateral parts of the chest wall. Ask the patient to breathe deeply. Observe and compare the mobility of 2 hands to assess expansion. Place the ulnar side or palms at symmetrical position of chest wall. Ask the patient to see E from top to bottom and middle to lateral, then cross 2 hands and compare tactile parameters of both sides. Heart. Palpate apical impulse. Usually use right hand. Palpate with palm firstly, and then with the ball of the second, third, and fourth fingers. It is normally located in the 5th interspace, just 0.5 to 1.0 centimeters, medial to the left mid-clavicular line. The impulsal diameter is 2 to 2.5 centimeters. Palpate precardium thrill. Palpate the auscultatory areas of every well and the 3rd and 4th interspaces at the left of sternum with ulnar side of the palm. Percussion. Lung. Let the patient put down arms vertically and breathe equably to relax muscles. The percussion is usually begun with the 1st interspace and then downwards, in the order of mid-clavicular lines, pre-axillary lines, and mid-axillary lines. Percuss from top to bottom and lateral to medial along each interspaces. Compare one side to the other looking for asymmetry. Percuss the lower boundary of lung is done along the right mid-clavicular line. The transition of percussion sound from resonance to dullness indicates the relative level dullness boundary, and from dullness to flatness indicates the lower boundary of the lung. That's the absolute level dullness boundary. Percussion of the lower boundary of lung is done along bilateral mid-axillary lines. The percussion sound will change from resonance to flatness at the inferior lung border. Proper technique. Hyperextend the middle finger of one hand and place the distal interphalangeal joint firmly against the patient's chest. With the end, not the pad, of the opposite middle finger, use a quick flick of the wrist to strike first finger twice or 3 times at each point. Heart. Percuss from left to right, outer to inner, and lower to upper. Percuss the left boundary of relative cardiac dullness. Percuss from the point which is 2 to 3 centimeters lateral to the apex. Generally in the 5th intercostal space, just medial to left mid-clavicular line. The percuss medially along an intercostal space until relative cardiac dullness occurs and mark it. Percuss in the 5th, 4th, 3rd, and 2nd left intercostal space sequentially in the same way. The right border of relative cardiac dullness detect the upper border of the lever. The percuss lever relative dullness border, no need to percuss again. Firstly, Then percuss the right cardiac bladder from the upper intercostal space, usually in the fifth intercostal space, and then from the lateral to the medial side. Percuss each intercostal space until the right second intercostal space and mark respectively. As to some patients, the right boundary does not exceed the right edge of sternum. There is no need to measure. Measure the distance from marked points to the anterior midline. Meanwhile, measure the distance between left midclavicular line and anterior midline. Auscultation. Lung. Ask the patient to breathe equably. Breathe deeply if necessary. The order of auscultation. Begin with the apex of the lung, from the superior to inferior, from anterior to lateral, and then to posterior of chest. Auscultation of the anterior and lateral chest is done along the midclavicular line, preaxillary line, and mid-axillary line, from top to bottom at each interspace. Compare the upper and the lower, left and the right symmetry parts, from superior to inferior, lateral to medial, or medial to lateral. Ask a patient to say "ee" with the same intensity. Auscultate from top to bottom, lateral to medial, or medial to lateral, and compare one side to the other looking for symmetry. Heart. The order of cardiac auscultation is anti-clockwise, following as the mitral valve area, pulmonary valve area, aortic valve area, the second auscultatory area of aortic valve, tricuspid valve area. Note the heart rate, cardiac rhythm, heart sounds, extracardiac sounds, murmur, and precardial friction sound. Mitral valve area is located at the apex of heart. If heart is enlarged, the location of the apex moves leftwards or downwards. The position of auscultation is at the strongest beating site. Pulmonary valve area is located at the left second interspace near the sternum. Aortic valve area is located at the right second interspace near the sternum. Systolic ejection murmur can be heard in this area when aortic stenosis occurs. The second auscultatory area of aortic valve is located at left third interspace near the sternum. Diastolic harsh murmur can be heard clearly in this area when aortic regurgitation occurs. Tricuspid valve area is located at the left fourth and fifth interspace near the sternum. Peripheral vascular signs and pulsus productus. Water hammer pulse. Grasp the palm side of the patient's wrist and raise the forearm limb overhead. The rapid and powerful pulse means water hammer pulse. Capillary pulsation sign. Press the end of the fingernails slightly to make local parts turn pale, and the pink edge extends and recedes with heartbeat. This is called capillary pulsation sign. That means the same as water hammer pulse does. Pulsus productus. During respiration, the pulse becomes weaker as the patient inhales and stronger as he exhales, or find an inspiratory reduction in systolic pressure over 10 millimeters of mercury. Neck. Jugular vein. Position the patient supine with the head of the table elevated 45 degrees and observe the filling level of the jugular vein. Normally, it is within 2/3 of the distance between superior edge of clavicle and mandibular angle at semi-sitting position. The distension of jugular vein beyond that extent is called jugular venous pressure elevation. Thyroid gland. The patient should be in sitting position Inspect and palpate thyroid gland. Note whether it is visible or symmetrical. Palpate isthmus of thyroid gland. Stand in front of the patient to palpate from superior sternal notch upwards with thumb, or with index fingers from patient's back. The soft tissue on the anterior surface of trachea can be touched. Judge whether there is thickening. Ask patient to swallow so as to feel the soft tissue sliding under fingers, and judge swelling and tumor. Palpate lateral lobes. Push the trachea gently on the thyroid cartilage with thumb. Put index and middle fingers of the other hand behind sternocleidomastoid to squeeze the lobes, and with thumb to palpate lobe. Then ask patient to swallow. Note the size, symmetry, and position of the lobe, as well as the presence of any nodules. Repeat for the other side. Auscultate thyroid gland with the bill of the stethoscope at upper and lower poles. Trachea. Position the patient sitting or supine and make neck erect naturally. The doctor puts index and ring fingers on both sternoclavicular joints respectively, and then puts the middle finger on the trachea. Observe whether the middle finger is in the middle. Palpate the gaps between trachea and sternocleidomastoid on both thighs with the middle finger to determine the position of trachea. Back. Position the patient sitting and expose the back adequately. Inspection. Observe thoracic shape and movement of respiration. Palpation. Identify tenderness when placing palms on the surface of chest wall and press gently from top to bottom, comparing the bilateral symmetry sequentially. Measurement of posterior thoracic expansion. Place hands on the back at about the 10th rib level, with thumbs parallel to the midline, and squeeze the skin from bilateral to the midline. Let the patient breathe deeply, and compare bilateral thoracic expansion. Repeat the procedure to check tactile parameters. Put the palms on the ulnar sides of the hands between the 5th and the 6th interspace on the mid-axillary line. Ask the patient to breathe deeply and palpate whether there is a lateral scrubbing sensation. Percussion. Ask the patient to bend his head and lean his upper body forward slightly, or have both arms crossed to make sure the scapula move to outer side as far as possible. The middle finger should be vertical to ribs. When percussing interscapular area, percuss each intercostal space in infrascapular area along the scapular line and the posterior axillary line, from top to bottom and lateral to medial. Percuss the lower boundary of lung on the back along bilateral scapular lines until the flatness occurs. Percuss diaphragmatic excursion. Percuss the bottom of lung during normal breath, and then ask patient to inspire deeply and hold it. Percuss downwards at scapular line to determine the lowest edge where the resonance change to dullness. Now ask the patient to breathe normally. Then expire as much as possible, and percussion is repeated from the lower boundary of lung upwards to find the highest edge where the dullness change to resonance. The distance between the inspiration and expiration levels is the diaphragmatic excursion. Auscultation. Auscultate the back along scapular lines and posterior axillary lines. Repeat the procedure for auscultation and vocal resonance as percussion. Spine. Slidingly press along the apices of spinous processes from top to bottom. Then the congestive skin trace appears. To observe whether the spine is having lateral curvature, press the apex of spinous process one by one from the occipital tuberosity with right thumb and define tenderness. Direct percussion. Vertically knock on spinous press of the vertebral body with a middle finger or percussion hammer to define tenderness. Indirect percussion. Put left hand on patient's head. Make a half face of right hand to knock on left. Then define tenderness. Press the vertebral costal points, intersection of the spine and costal arc, and the lumbocostal points, intersection of the costal arc and the exterior edge of psoas major with thumbs to observe whether there is tenderness or not. Put the left palm on costal vertebral angle, which is the angle of the spine and costal arc. That is the kidney area. Make a fist of right hand and knock on left hand with light to medium strength to observe whether pain or not. Abdomen. Position the patient in supine and expose the abdomen fully. From xiphoid to the pubic symphysis region, other parts should be covered. And ask the patient to genuflex, breathe calmly, and relax abdominal muscles, and the patient arms kept at the lateral sides of body. The patient should empty the bladder before the physical examination. Inspection. The light should be sufficient and mild. Inspect tangentially if necessary. Observe abdominal contour, symmetry, gastrointestinal pattern, peristalsis, abdominal veins, skin, umbilicus, and abdominal respiration. Auscultation. Auscultate both sounds at umbilical region or right lower quadrant for 1 minute. Check for abdominal vascular murmurs. Systolic murmurs in umbilical region indicates abdominal aortic aneurysm, abdominal aortic stenosis. Systolic murmurs in left and right upper abdomen indicates renal artery stenosis. Systolic murmurs in bilateral hypogastric region indicates iliac artery stenosis. Continuous bruise near umbilicus or below xiphoid process indicates hepatic cirrhosis with portal hypertension. Palpation. Light palpation. Palpate from the left lower quadrant to the umbilical region anticlockwise. Identify any area of tenderness, rigidity, or any mass. Deep palpation. Move from the left lower quadrant to the umbilical region anticlockwise. Identify an area of tenderness or rebound tenderness. To measure some common tenderness points, first, McBurner point is at the outer one-third point of the link between the anterior superior iliac spine and the umbilicus. Second, point of upper ureter is at the intersection of the umbilical horizontal and the exterior margin of the rectus abdominis. Third, point of middle ureter is at the intersection point of the anterior superior iliac spine horizon and the exterior margin of the rectus abdominis. Ask the patient to practice deep abdominal respiration 2 or 3 times. Single hand palpation of the liver in the right midclavicular line. Extend the metacarpal phalangeal joint of the right hand with 4 fingers together and parallel to the costal margin. Start at the level of the anterior superior iliac spine. When the patient exhales, move the fingertips further inward. When inspires, the liver comes down and you can try to meet and touch the liver edge. Gently repeat as you advance your hand toward the hepatic margin with each inspiration until you touch the hepatic margin or rib border. Bimanual palpation of liver in the right midclavicular line. Place your left palm below the right lumbar region to support and press forward it. And place thumb on the costal part, following steps as above. Bimanual palpation of liver in the anterior median line. Start palpation at the level of the umbilicus, following steps as above. Check the hepatojugular reflux sign. When palpate, enlarge the liver. Identify any tenderness at the point of gallbladder. Place left palm under the right thorax. Press the ball of left thumb just on the point of gallbladder, the intersection points of the right midclavicular line and the right costal margin, and ask the patient to take a deep breath slowly. A pain induced by downward motion of the inflamed gallbladder touching the forcibly pressed thumb on inspiration is called the cholecystitic tactile pain, and a tenderness increases with a sudden stop in inspiratory effort constitutes a positive Murphy's sign. Bimanual palpation of spleen. With your left hand reaching over and around the patient to support and press upwards the 9th to 10th lower left ribs. Flatly place your right palm on the umbilical region with your fingertips pointing to the costal arch vertically. Following steps as palpating the liver. If the spleen can't be palpated, repeat the way referred to above with the patient lying on his right side with his right leg extended and his left leg somewhat flexed at hips and knees. Bimanual palpation of kidneys. Place your left palm behind the supports the patient's lumbar part and place your right hand on the upper abdomen with your fingertips parallel pointing to the ribs. Transfer slightly. As the patient takes a deep inspiration, press hands together to capture the kidney. Keep the patient in standing position if necessary. Check the suction splash. Place ear approach to the upper abdomen or put stethoscope on the upper abdomen when you vibrate the patient's stomach area with ballonment. It is positive if you hear a very loud splash as air and fluid impact. If the patient's stomach is empty on early morning or more than 6 to 8 hours after meal, a very loud splash suggests pyloric obstruction or gastric dilatation. Percussion. Percuss the abdomen in all 4 quadrants as the sequences of palpation. Check any percussion pain of the liver. Check the shifting dullness. Keep the patient in supine position. Percuss leftwards at the level of the umbilicus from the regio mesogastrica. When the sound turns dullness, keep your finger there to mark a spot and then ask the patient turn right and percuss again. It indicates the dullness shifted if the dullness changes to tympany. Repeat the same way on the other side. Percuss left first, then right at the umbilical level. Check for the abdominal reflexes. A light stimulus is passed across the level below the costal margin, the umbilical level and the level above the glans, stretching from the outer aspect towards the midline. Observe the constriction of the abdominal muscles following the stimulus. Upper limbs. The patient is at supine position. Expose the upper extremities to inspect skin and joints. Inspect hands and nails. Palpate anterior, posterior, and lateral aspects of each interphalangeal joint and metacarpophalangeal joint with your thumb and index finger. Ask the patient to extend spread fingers of both hands, move claw-like hands, clench fists, and make the palmar opposition of thumb. Ask the patient to hold and resist your index and middle fingers of each hand. Palpate the surface of the wrist. Ask the patient to keep dorsal expansion and palmar flexion. Palpate the olecranon and the condyle of humerus. Palpate the epitrochlear node in the groove between the biceps and the triceps muscles, about 3 or 4 centimeters above the medial epicondyle. Ask the patient to flex and extend the elbow joint freely, then to counteract the resistance by flexion and extension. Expose the shoulder to inspect the shape. Palpate the shoulders and the surroundings. Check the shoulder joints movement by asking the patient to touch the opposite ear around above his head. Ask the patient to close his eyes and check the pain and tactile sensation by lightly touching the symmetrical parts of upper limbs with a toothpick or a cotton bud. The biceps reflex. The patient's forearm should be partially flexed with the elbow joint relaxed naturally. Place your left thumb firmly on the biceps tendon. Strike your thumb with the percussion hammer. It is normal when you see the contraction of the biceps muscle and fast flexion of the forearm. The triceps reflex. Abduct the patient's upper arm and flex the elbow joint partially and naturally. Strike triceps tendon above the olecranon with the percussion hammer while you support his relaxed upper arm with your left hand. Use a direct blow. It's normal to see the contraction of the triceps muscle and forearm slight extension at the elbow. The radial-prosteal reflex. The patient's forearm should be partially flexed and semi-pronate. Support his wrist with your left hand to keep the wrist relaxed. Strike the styloid process of the radius directly with the hammer. Observe the contraction of the brachioradialis muscle, flexion at the elbow, and pronation of the forearm. The Hoffman sign. Hold the patient's wrist with your left hand. Use your index and middle finger of the right hand to clip his middle finger. Pull it upwards until his relaxed wrist is slightly hyperextended. Flick his middle fingernail with your thumb tip. Observe the palmar flexion of other fingers, which is the positive result. The lower limbs. Expose the lower limbs to inspect the shape and skin. Palpate the inguinal region to identify any mass or hernia. Palpate the horizontal group of inguinal lymph nodes below the inguinal ligament. and the vertical group close to the upper portion of the greater saphenous vein. Palpate femoral pulse in the midpoint located between the anterior superior iliac spine and the pubic symphysis. Hold patient's limbs to make his hip joint flexion, internal rotation, and external rotation. Place your hands on thigh and ask patient to flex the hip against the downwards resistance from your resisting hands. Palpate the anterior, posterior, and lateral aspects of the knees. The floating patellar test. Firmly grasp the thigh just above the patient's superior patellar pole. Thus press the suprapatellar bursa to force fluid to the bottom of the patellar. With the index finger of the other hand, push the patellar vertically and sharply back against the femur. The patellar strikes the joint surface when pressed, flows when relaxed. It is a positive sign if you get the sensation. Palpate the ankle joint and the Achilles tendon. Press the front of the shin for 5 seconds with thumbs to check the patent edema. Use index and middle fingers to palpate dorsalis pedis between the first and second metatarsal bone before the ankle joint. Ask the patient to dorsiflex and plantar flex the ankle joint. Test the muscle strength of the dorsiflexion and plantar flexion of the feet by asking the patient to push down and pull up against your hands. Ask the patient to invert and invert the ankle joint, then to flex and extend the toes. Ask the patient to close his eyes, check the pain and tactile sensation by lightly touching the symmetric parts of lower limbs with a toothpick or a cotton bud. The knee reflexes. Support the patient's popliteal fossa with your left hand in somewhat flexed position about 120 degrees. Strike the quadriceps femoris muscle tendon below the patellar with percussion hammer. Extension of the legs is normal. The ankle reflex. Ask a patient to flex at knee and hip. Abduct and external rotate the lower limbs. Dorsiflex the ankle to 90 degrees with your left hand. Strike the Achilles tendon with percussion hammer. Observe contraction of the gastrocnemius with plantar flexion of the feet. The patellar columnus. Ask the patient to extend the lower limbs and grasp the superior border of the patellar with your index finger and thumb. Then push it downward to distal and quickly, for several times and maintain it. The patellar will jerk up and down from the rhythmic contraction of the quadriceps femoris. It is the manifestation of a situation of the tendon reflex. The ankle columnus. Ask the patient to flex the knee and hip partly. Hold the patient's leg with one hand and the other hold the front of sole to support the knee in a partly flexed position. With your other hand, sharply dorsiflex the foot and maintain it in dorsiflexion. Rhythmic contraction of the gastrocnemius and the soleus muscle cause the foot to alternate between dorsiflexion and plantar flexion. Its significance is the same as the patellar columnus. The pathology reflex. Babinski sign. Stroke the lateral sole of the patient's foot with a bamboo scrubbing from the heel toward the toes and then curving toward the great toe. The classic positive sign is the dorsiflexion of the great toe and the fanning plantar flexion of the other 4 smaller toes. Oppenheim sign. Great toe dorsiflexion is elicited with pressure applied by thumb and index finger of your left hand to the examiner's left anterior tibia. Pressure stroke should begin at the upper 2/3 of the tibia and be continued to the ankle. Test the right tibia with your right hand in the same way. Meningeal irritation sign. Kernig sign. With the patient supine, passively flex the hip to 90 degrees while the knee is flexed at about 90 degrees. Then straighten the knee. It is normal to extend to or over when 35 degrees. The positive sign is spasm of the flexor muscle. Pain while extending the knee and the resistance to further extension. Buzinski sign. With the patient supine position and the limbs extended, place your hand behind the patient's head and press the other hand on his chest. Then flex his neck forward. Flexion of the hips and knees at the same time is the positive Budzynski sign. Nuchal rigidity. Place your hand behind the patient's head and the other hand on his chest. Then flex his neck forward. It is the neck rigidity if you feel the resistance increased. The significance of the positive sign indicates the meninges irritate, as in meningitis, suprarachnoid hemorrhage, and intracranial hypertension. Coordination movements gauge the motion of the lumbar vertebral. Ask a patient to stand up to take finger-to-nose test. From slow to fast, open the eyes first, then close the eyes. Do the diadocal kinesia quickly. Extend the palm, pronate and supinate the forearms quickly. Romberg sign. Ask the patient to stand with the heels together and to hold his arms straight in front of him with eye closed. Observe the gait. Ask the patient to walk 5 to 10 meters. The lumbar flexion, extension, lateral bending, and rotary motion. Physical examination to the end. Tidy up the patient's clothes and the bed. Say, the physical examination is over. Are you tired? Thanks for your attention. Wash hands.